Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jennifer Blanchette. Today's episode is the first in a series titled Key Decisions in HIV Care, featuring expert insights on critical HIV management steps with a focus on individual patient needs. During this episode, Dr. Daniel Kuritzkes from Boston, Massachusetts, and Dr. Chloe Orkin from London, United Kingdom, discuss important considerations when switching antiretroviral therapy in patients with viral suppression on their current regimen. The discussion includes guideline recommendations and data supporting different switch regimen options, such as single-tablet triple therapy, 2-drug oral regimens, doravirine-based regimens, and long-acting injectable therapy. For more information about Dr. Kuritzkes and Dr. Orkin, and for a link to additional educational content from this program, including downloadable slides, please visit the show notes for this episode. Now let's get started and hear what Dr. Kuritzkes and Dr. Orkin have to say, beginning with Dr. Orkin.
Thank you so much, Jen, and it's wonderful to be here with my very, very brilliant colleague, Professor Dan Kuritzkes, and we're going to be talking about optimizing switch strategies for people with viral suppression. And I guess to some extent, the first principle that I'd like to bring out is really what it says on the tin, with viral suppression. And I guess that the aim here is to make sure we do no harm, we don't upset the apple cart, and we maintain suppression. And this is a guiding principle for everything that we do. So having considered that and taken that sort of into account, we'll talk about what to consider when switching to single tablet regimens, some recommendations and guidelines, some thoughts around 2-drug regimens. We'll consider the new NNRTI doravirine, and then we'll move on to long-acting injectables and come up with some summary take-home points. So what are reasons to consider a switch during viral suppression? Well, there are good reasons and not good reasons. Good reasons are to simplify a treatment, for convenience, to enhance tolerability or to decrease toxicity, so preventative or sort of mitigating a toxicity, or a drug interaction or drug-food interaction, and really to adapt to allow life goals to be met, such as conception, or when a pregnancy may occur, and finally to reduce costs. Many of us health economies are, under pressure. Inappropriate is to use the newest, shiniest drug, or to put a patient at risk by reducing the cost of a regimen at the price of toxicity or intolerability. So considerations, and I think you can see on the slide the biggest box is the grey box talking about drug resistance. And this is because really we have been burned in the past by switching to the newest regimen and finding that we did not manage to maintain the viral suppression. And the older people in the audience, like myself, will remember the Switch Merck study, which was a study when we first got raltegravir, and we were very excited, and it done very well in treatment-naive individuals. So we took people who were undetectable on lopinavir, and we either kept them going or we switched them to raltegravir, and there was a failure rate. We had to interrupt the study due to adverse consequences to those that switched to raltegravir. This is because there was baseline resistance archived, which we didn't know about and didn't think about because people had previously failed regimens. And this is what underlies this grey box, which is very important. And that really means we've got to review the history for possible virological failure. So if we can't find genotypes at the time of failure where there's drug pressure and we can actually see what's evolved, then we need to read the history, read the tea leaves, and try and understand that someone has failed on something and therefore what resistance is likely. We need to review all available resistance tests and only consider a switch if a new regimen is likely to maintain the suppression. Bearing in mind that within-class switches usually maintain suppression if there's no resistance to drugs in that class. And you have to be cautious when downcycling, so going from a high genetic barrier to a low genetic barrier, so going from a PI to an NNRTI, for example, or a second-generation integrase inhibitor to a first-generation integrase inhibitor. And if you are unsure, discuss it with colleagues, more experienced colleagues. Safety is important. We also must think about, has someone had this drug before and had a problem with it? Are they likely to develop a problem related to their own comorbidities? We also must consider comorbidities and other conditions, which include things like hepatitis B and various sort of organ problems and conditions such as pregnancy. So these are all factors to consider. there are a lot of studies that have been done supporting switching from suppressive treatment to a single tablet regimen. And I would underline to you that based on the learnings from the Switch-Merck study, what we have realized is that we should switch people who have been undetectable for generally at least 6 months, tend to be most of the inclusion criteria. And if you do that, you can see that switching to modern regimens is generally successful, and non-inferiority is achieved for all of these studies. So you can see that there's a number of different new regimens that have been switched to here. And these are studies which sort of span 2015 onwards. So really from the point where we had TAF, FTC, and rilpivirine, and TAF, FTC, and elvitegravir, cobicistat onwards. In orange is highlighted the only studies in whom participants actually had any inherent baseline resistance, and it was small amounts of it. So this really underpins the point about how important it is to know the history and know the resistance. But I don't know, Dan, whether there's anything you'd want to say on this particularly.
No, I think it is important to have that resistance treatment history and to keep that in mind when you are making one of these shifts, and to recognize how few of the studies have really looked at people who had known pre-existing resistance with just a couple of exceptions. And so that continues to be an important issue.
Totally agree. So what are the recommended regimen switches? So this is a little look at the guidelines and see where they really place their attention. So for DHHS, they focus on the issue of within-class switches versus between-class switches. And they say that generally you can switch easily between classes so long as you don't downcycle in the way that I mentioned. But when you go between class, you really have to think about the genetic barrier and not make mistakes in that regard. For the IAS USA, they talk about the fact that switching to a single tablet regimen is a well-evidenced thing to do. They focus on Hep B co-infection and really thinking about that before switching and making sure someone's immune or vaccinated. And then they specifically comment on the evidence, the weighted evidence around the use of 2-drug regimens, concluding that there are several very well-evidenced regimens, many of which Dan is going to cover. For EX, they also draw out the distinctions between within and between class switches, focus on Hep B, and they specifically comment on the RCT and meta-analysis supported regimens, which are dolutegravir, rilpivirine 3TC, or boosted PIs plus 3TC. So that's what they really focus on. And I think it's interesting to see how the different wise heads have converged to come up with some recommendations. Importantly, there is monitoring after switching. So this is really important now with COVID. COVID's not over, and certainly we've been going through it for some time. So if you switch someone, there is certainly an expectation you would need to check their viral load at the very minimum at a month, and also check safety bloods in certain instances. And in the DHHS guidelines, they recommend more intensive follow-up. And I think it really depends on who your patient is and your relationship and how well you know them and what the likelihood of harm is in terms of you have to follow people up, but it's not a time-neutral event, and it does require bringing someone back to the hospital for blood tests, and you may not want to do that in the midst of a catastrophic wave if the person is stable and there's a sort of a non-major reason for switching. It's a pleasure to hand over to Dan to continue with the next part of the talk.
Well, thanks so much, Chloe, and thank you for setting the stage so nicely in that introductory section. I should return the favor and say what a pleasure it is to be sharing the program with the extraordinary Professor Chloe Orkin. So we'll go on with the first of several studies that I'll review for you. And this is the TANGO study. This slide shows the results of the SWITCH study. Recall that Gemini was a pair of studies that looked at the initial use of dolutegravir 3TC as first-line therapy as a 2-drug regimen. And TANGO asked, what about switching people who were already suppressed on a 3-drug regimen to a 2-drug regimen? And they particularly focused on people who were on a TAF-based 3-drug regimen and randomized them either to continue on their 3-drug regimen, which could have included any so-called anchor drug, boosted PI, integrase inhibitor, and the like, or switching to DTG 3TC. Because this was a switch study, the way the outcome is organized is that you're looking at the incidence of virologic failure the occurrence of viremia greater than 50 copies per mil. And you can see on the left side of your screen here that there were extraordinarily low rates of virologic failure, 0.3 and 0.5% respectively. The difference between those arms then shifting over to the right was really minimal and falls very comfortably within the non-inferiority margin, demonstrating that DTG-3TC is just as good as continued triple drug therapy. A more traditional endpoint looking at the proportion that sustained virologic suppression shows nearly identical numbers at 93% and met the non-inferiority margin for this key secondary endpoint. There were no confirmed virologic withdrawals in the two-drug arm, and there was only a single confirmed virologic withdrawal in the TAF-based arm, and there was no resistance detected at failure in that person. There were discovered retrospectively 7 participants, 4 in the two-drug arm and 3 in the continued triple drug arm, who turned out to have an M184V or I mutation in their proviral DNA at the time they entered the study, and that had no impact on the outcome in the trial. The study went on to look at some additional secondary endpoints, including changes in lipids, hemoglobin A1C, fasting glucose, and fasting insulin at week 48. And if you excluded those who were already receiving lipid-modifying agents, the lipid changes favored a switch to the two-drug DTG-3TC regimen as opposed to continuing on TAF-based ART. And there were significant reductions in various lipid parameters in those who switched to the two-drug regimen. When stratified by previous use of boosting agents, so this would be either a ritonavir-boosted protease inhibitor or cobicistat-boosted PI or elvitegravir, there were statistically significant favorable changes for the switch to a two-drug arm as opposed to continuing on the boosted regimen. And likewise, there were significant reductions in the various lipid parameters. Looking at glucose control and insulin resistance, A1C and fasting glucose changes were minimal and comparable between both arms. Fasting insulin changes were statistically more favorable in the dolutegravir 3TC arm compared to the continued TAF-based ART in the boosted subgroup, those again receiving a cobicistat or ritonavir, and that was again statistically significant. What about weight change, an area of increasing concern? Overall, weight gains were minimal and comparable between arms, as you can see in the slide here, that the adjusted mean weight gain was about 0.8 kilos in each of the arms, and really looked at very much like the kind of weight gain you would expect to see in this population, regardless of whether they have HIV and regardless of what therapy they're on. And only about 3 or 4% in each arm showed an increase of 10% or more above their baseline weight. Looking at a different switch study, again a two-drug regimen, but now looking at dolutegravir with the non-nucleoside RT inhibitor rilpivirine as a novel two-drug regimen. The SWORD-1 and SWORD-2 studies were switch trials that took people from different regimens and randomized them to either continue on those regimens or to switch to DTG rilpivirine. And the primary endpoint, again, was maintaining an RNA less than 50 copies. And that study demonstrated non-inferiority of the two-drug arm compared to the three-drug arm and the two studies combined, with only 10 people or 1% having confirmed virologic withdrawal through extended follow-up out to 100 weeks. 3 of those 10 had treatment emergent NNRTI resistance mutations, as you can see in the slide shown over here. And they came from a variety of previous regimens, although 2 of them did have prior experience with efavirenz. Looking at a shift to a three-drug regimen rather than a two-drug regimen, the DRIVE SHIFT study took people who were suppressed on a regimen and randomized them to continue on that regimen or to switch to the regimen containing a novel NNRTI doravirine in combination with 3TC and TDF. This was an immediate versus delayed switch. So participants either switched immediately or after 24 weeks, and by week 24 then, or subsequent to week 24, everybody in the study was then switched to the doravirine containing regimen and followed out to week 48. This complicates the analysis of the study somewhat because you're really comparing a group of people who had been on the new regimen for 48 weeks to a group of people who had been on it for only 24 weeks. And the primary endpoint, again, is having a virus load less than 50 copies at week 48 versus the 24 weeks in the delayed switch arm. So here are the data, and they're parsed by looking at the different intervals. And so the immediate switch group is the ISG group, and the delayed switch group is the DSG group. Here we're looking at longer term follow-ups, and what you can see is that in the immediate and delayed switch groups, there are very low rates of virologic failure, and there are comparable and high rates of maintaining viral suppression. The drive shift study also explored weight change over time, and here they looked at the change in weight following the switch to the doravirine-based regimen. So for the immediate switch group, they start tracking weight change from day 0, and for the delayed switch group, they start tracking weight change from week 24. What you can see is that the weight changes are really, again, fairly modest, about a 0.7 kilo gain in weight for the immediate switch group in the first 24 and 48 weeks, with some additional weight gain in the subsequent 2 years. The delayed switch group had about a similar weight gain at week 48 as was seen in the first 24 weeks for the immediate group, and again continued at the same pace in the subsequent weeks. So nothing beyond what one might expect as a regular gain in weight for an aging population of adults. And with that, before turning this over to Dr. Orkin to talk about long-acting therapy, Chloe, when you're considering a switch to a novel regimen for, say, simplification, how many of your patients do you think of using a 2-drug regimen in or switching to an alternative 3-drug regimen?
Well, I have to say I am quite of the thought that why use 3 drugs if 2 drugs will do, and there's good evidence that 2 drugs do work. And I think the key point, which is the point you've made so eloquently, is that not all 2-drug regimens are created equal, and some are clearly much more robust than others. But I would prefer to use fewer drugs if I could. So I certainly would be keen on a 2-drug regimen. I think the other thing that I am thinking a lot about when I switch is weight. I'm not quite sure what exactly I'm thinking because we're very unclear about what the mechanism is, whether it's a return to normal effect or whether it's a pathological effect. But I do certainly think about it when I make switches. And I think that last study, the drive shift study is an interesting study, switching away from, switching to an NNRTI in a small proportion of people was away from an integrase inhibitor. Mm-hmm. And you don't really see an improvement, but in that small category of people on integrase inhibitor, there was a trend towards improvement, but no actual improvement. So, my focus is I would think about switching to 2 drugs, and I'd also think about trying to avoid weight gain.
Yep, all good points. Mm. All right, take it away.
Thank you. So Atlas and Flare, just a reminder, these are the 2 sort of registrational studies for long-acting cabotegravir or pivirine. Atlas study is a switch study for people that are already virologically suppressed for some time. And the Flare study was for people who were started their first line of treatment, were given an oral regimen for 20 weeks, and then given the long-acting treatment. So we're talking about monthly treatment in both of these studies. And the people that were included were adults who had to be hepatitis B negative undetectable for 6 months with no resistance to any of the existing, or no resistance to rilpivirine because integrase inhibitors weren't sequenced. So those are the two studies I'm going to talk about first. And in Atlas, we've got data out to week 48, and what you can see here is non-inferiority for the long-acting cabotegravir rilpivirine, which is in blue. You can see this is for the primary endpoint of virological non-response, as well as the secondary endpoint of virological success. In the FLAIR study, which is the originally treatment-naive people, once again, this is week 96 data, so a year of longevity. And here we see for blue, for cabotegravir rilpivirine, once again, non-inferiority for virological failure and virological success. Importantly, there was no additional virological failures in year 2. And I think that is an important thing for us as clinicians to know, that if people get through the first year, they're very likely to remain good and undetectable. And I think this is important because in this first year of data, when these two presentations were made, there was a lot of interest in the treatment emergent resistance with long-acting cabotegravir rilpivirine. And I guess it shouldn't really have been that surprising given the data that Dan just presented of the SWORD study and how people on rilpivirine and dolutegravir did fail with resistance. And they tended to fail with rilpivirine resistance and also in one case with integrase resistance. So with cabotegravir here, what we see is a pattern, is that people with particular subtype, predominantly A6, which leads to certain polymorphisms being present at baseline, particularly with NNRTI baseline polymorphisms on retrospective sequencing, led to failure. With NNRTI resistance, but also integrase inhibitor resistance, including the BAD 148 pathway. So this is where we got to at end of year 1. So looking at the next study, which is the Atlas 2M, and that's sort of the ongoing study. So there wasn't an Atlas, sort of the Atlas people, basically, the participants went into the Atlas 2M. And Atlas 2M means 2 monthly, 2M is for 2 monthly versus 1 monthly. So the people in the Atlas study who were on injectables, the people who were on the Atlas study who were on orals, were then put into this study, chose to enroll into this study with a whole lot of other people who weren't part of the study. And they went on to receive an oral lead-in, and then those who weren't on injectable already, and then they went to 2 monthly versus 3 monthly cabotegravir rilpivirine. What you see here is the outcomes at week 96 presented this year. Once again, you don't need to be a statistician to see that there was non-inferiority for virological failure and success for this study. And I think in terms of the failures, here it's an interesting picture. So we see for the 8-weekly arm, 8 failures versus 2 for the 4-weekly arm. And we see failure with rilpivirine resistance mutations, as we've seen previously. And we see treatment emergent rilpivirine mutations are very similar to what we saw previously. And we also see here failure with integrase inhibitor mutations of a similar ilk to what we saw previously. Now, on the right-hand panel, which is really why we're doing these switches, is cabotegravir long-acting with rilpivirine are well tolerated. And 98% of injection site reactions were grade 1 and 2, and the median duration of the reaction was 3 days. And patients preferred cabotegravir long-acting with rilpivirine over oral therapy. Now, this was the case in the FLAIR study out to week 96. It was the case in the original Atlas study up to week 48. It was the case in the Atlas 2M study. And interestingly, and not surprisingly, it was also the case in people who had previously received monthly long-acting treatment. They preferred the 2 monthly. And this is always, I always get a sense that the audience at this point, I get sort of a sense of it's like bristling in the audience by some people and thinking, well, why is that so interesting or surprising? Why is she talking about that? Because obviously these people went into a study, they're trial participants, they wanted long-acting treatment, and so what if they were satisfied? Well, what I have said many, many times, and I'm sorry to bore those of you who've heard me speak before, but I would say again, I don't plan to line my patients up against the wall and hold a gun to their head and force them onto long-acting treatment. We would only be giving it to people who want to take long-acting treatment. So what we need to know from the treatment satisfaction studies is what we found out, which is that if you wanted long-acting treatment, then you were satisfied and you were glad you did it by the end. And there were very, very few withdrawals across the studies for people who had injection site reactions. So I think that's an important point to note. And that sort of leads us to the point where it's actually been approved, FDA indication as a complete regimen for people that are suppressed with no failure, requires an oral lead-in dose. You get the injections every month. And in Europe, you can actually, it's also licensed for 2 monthly. And DHHS has come up with a statement on use as an optimization strategy for people undetectable for at least 3 months. And they cite the obvious caveats. They include pregnancy or potential conception as a contraindication. And I think this is because, as ever, pregnant women were excluded from studies, and the idea of protecting women from research rather than through research was adopted. And they also comment on avoiding any particular drug interactions. Interestingly, Dan, I mean, you'll be more familiar than me, but the DHHS guidelines specifically comment on people who may benefit from these regimens in order to reduce stigma, discrimination, fear of disclosure, fear of discovery. I mean, how important is that so far in your practice in terms of this?
It hasn't been a huge driver, but I can certainly see that for certain people that having a bottle of pills at home runs the risk of disclosure. We do have a number of people who are followed in our practice who haven't disclosed to family members. And although they haven't yet opted for injectable therapy, they are constantly concerned about where to sequester their tablets and their medications so that they're not discovered and have an inadvertent disclosure of their status in that way. So I think it's going to be quite individual, but I can certainly see why that might be appealing to some patients.
Yeah, absolutely. And there was some other data, which actually I presented at HIV Glasgow, on direct-to-inject switching without an oral lead-in. And this was based on the FLAIR extension study where at the end of the planned endpoints, secondary endpoints, people who were on the oral therapy were allowed to opt to go on to the injectable therapy. And then together with their physician, they were actually allowed to opt whether to have an oral lead-in or have the injection straight away. And this was because there were so few safety events in the entire program that the FDA granted the option to actually choose to dispense with the oral lead-in, which was really there for safety. And you can see that the outcomes were just as good. And actually, in terms of pharmacokinetics, there were no differences. And there were no concerning issues around liver events or skin events or allergies or any hypersensitivities in those that went direct to inject. So here we get to this interesting, rather interesting regression. And this was really an attempt to try and understand the contributing factors, the drivers of failure, because as I've shown you, very few people actually fail these combinations, less than 1% of every study. So how do you work out with such small numbers what's actually going on, who is actually failing? So what they did is they made a model based on a post hoc analysis of phase 3 data and did an elimination model based on 10 covariates. And what they found is that there were particular factors that seemed more associated with failure. And that was recovery and resistance mutations at baseline, which is the strongest predictor. The log, the pharmacokinetic drug level of week 8 rilpivirine trough, the baseline H1 HIV subtype A6, which is found in Russia, which is why all of those Russian sites had people that failed, because that's the polymorphisms that are part of that virus, and a high weight of over 30 BMI. The 8-weekly dosing was not a factor, didn't come out in the analysis. So what they found is that if you have more than 2 of these factors, then you are at a higher risk of failing, but not if you have less than 2 of them. So in the pandemic, I mean, I think I've already expressed some reticence around switching and saying that one should potentially postpone changes in the height of a wave, or if you think the wave is coming. And I think I don't mean to jest, but I think that HIV physicians have in many cases been at the forefront of the sort of research response, the clinical response to the pandemic, and certainly given our expertise at predicting and looking at and understanding viral resistance, we've been in a position to predict what's been going on in terms of escape and, in terms of variants. So I think I'd advise patients to talk to their doctors about whether it's a good time to switch, given what might be happening in terms of the potential wave. And I think if you are switching, bear in mind regimens require little monitoring and consider the timing. But I don't know whether you'd want to say anything else to that, Dan.
No, I completely agree. I think we really need to be very aware of the context in which switches are being made. And because one would want to have a little bit of extra scrutiny to ensure that people are tolerating their new regimen and that there aren't any disruptions that are occurring with a switch, that if it's challenging to do that because patients can't come in for visits or can't get to a lab for testing, that if there's no urgency in making a switch, that waiting until the situation is normalized would be advisable.
Absolutely. So I guess in summary, people with virological suppression and no history of drug resistance have lots of options with a very low risk of virological failure. For those not experiencing adverse events, it's critical that the switch strategy offers safety, convenience, or cost benefit, bearing in mind that there's now very good evidence for certain 2-drug regimens that are excellent. Although we don't have 20 years of data. Monotherapy is totally out and should be avoided under all circumstances. And people with virological suppression and a history of single-class resistance definitely have treatment simplification options, but you've got to review the history forensically, and you've got to review all genotypes. And you can infer viable switch strategies from studies of second-line therapy. And I think that last point is a very important point and sort of takes us sort of back to the Dawning study, which taught us a lot of things about what could be done with very resistant people. So that's where I would end and hand over to Dan to moderate the questions.
Well, thanks, Chloe. That was really a stellar presentation, as always. We do have some questions, and one of them, the first one is, I think, directly on the point of why injectable therapy is different than oral therapy. And so the question is, how do you handle people who are on a proton pump inhibitor who are interested in long-acting injectable cabotegravir and rilpivirine?
So are you asking me?
Yes.
Okay, so because of the bypass of hepatic metabolism, it's not a concern.
Right. I think that's exactly the point to be made here, that the PPIs are contraindicated with rilpivirine because they interfere with the absorption of rilpivirine. They don't accelerate its metabolism. And so if you're injecting the drug, then PPIs are no longer a problem. And in fact, that might be a situation in which the injectable would be preferred to oral therapy.
Yeah, and just one more thing I'd say, like learning from other specialties, like in psychiatry, one of the key reasons, that they tend to move to long-acting treatments is because people are often on lots of other agents, and to avoid, first-pass metabolism is often a great benefit. Right.
I might make some additional comments on that analysis that looked at the baseline factors predicting failure on long-acting cabotegravir and rilpivirine. The challenge for clinicians is that among the 4 factors that were identified as being the strongest predictors, only one of them is readily measurable in the office, and that's obviously the BMI. If you're fortunate and have a catalog of prior resistance tests, then you could get at whether there were or were not rilpivirine resistance mutations that have been documented in the past. But otherwise, if you don't have that information, doing resistance testing on proviral DNA is still sort of spotty in terms of its acceptance and availability. Obviously, most people don't have access to rilpivirine trough concentrations, and once you've had a low concentration at week 8, it's a little late to fix it. And obviously, for the same reasons that people may not have resistance information available, they may not have the subtype available. And you can't assume that just because somebody comes from Russia or Eastern Europe that they have A6, although that is where the virus is most common. And A6 by itself was not a risk for failure. It was really A6 together with other factors. So it is challenging. And I guess the only other point to make is the one reason that cabotegravir trough concentrations didn't also come out in that model is that they were highly correlated with BMI, and so didn't survive the elimination. So another question that we have is, do you see the direct-to-inject cabotegravir or rilpivirine becoming the standard of care when initiating these long-acting injectables? I can give my opinion, and then
go for
it. I think once we have sufficient experience, then I would say yes. Obviously, the concern is that these long-acting injections produce sustainable drug levels that persist at therapeutic concentrations for several months and may still be detectable in some patients as long as a year out. And if somebody's having a true hypersensitivity reaction, it may take only very little drug to sustain such a reaction. And that's the main concern for why there is currently the requirement for the oral lead-in. I think as we have more experience and get more comfortable with the safety of these agents, and we have extensive experience with rilpivirine, of course, less so with cabotegravir, then it'll probably be eventually acceptable to go straight to inject.
Yeah, I mean, I'm with you. I feel very cautious about it. And I completely dissuaded my patients. In fact, I told them it would be over my dead body that they did that in the FLAIR study. I'm afraid I probably shouldn't admit that publicly, but I just really didn't think it was a good idea at that time. We didn't know enough, in my view. But I think there are people, for example, people who have problems with swallowing, people in hospital, people with absorption problems, GI issues, where you might want to go, or psychiatric issues, they just aren't going to take it. They're somehow being got undetectable, that you might actually go direct to inject. But it's certainly not, I agree with you, we need more data.
There's an interesting question here about a completely different kind of two-drug regimen, asking what about a two-drug combination with boosted darunavir and dolutegravir? And the questioner points out that the Dualis study showed very high success of this regimen that avoids some of the problems around the use of tenofovir-based regimens or a need for adjustments for GFR, and also there's no concern around archived 184V mutations. I think one of the issues, a lot of the push, especially today, a lot of the push to two-drug regimens has to do with simplifying therapy. And for many people, a boosted regimen wouldn't necessarily be considered simplification, although that is obviously in the eye of the beholder, but there are more drug-drug interactions that may be possible from the use of a booster. And as we saw in the Tango study, people who switched from boosted regimens to the two-drug regimen were the ones who had the best improvement in their lipid parameters because of the potential effects of either ritonavir or cobicistat. The other point that I would make is that this two-drug regimen would really be a three-drug regimen because you are giving the booster. It wouldn't be available as a two-drug co-formulated tablet, although I suppose there's no reason that one couldn't manufacture such a tablet if there was a motivation to do so. I think that given that we're no longer using boosted elvitegravir as an integrase inhibitor, and the boosted PIs generally have been relegated to alternative regimen status, there wouldn't be very many people, I would think, of using a regimen that included boosted darunavir with dolutegravir as a switch regimen. What about you, Chloe?
Yeah, I mean, I completely agree with every point you've made. The only other thing I'd say is that the things that have really worked have had an RT with them, RT inhibitor. So it's either an NRTI or an NRTI. Those are the things that are actually in the guidelines. Everything that's in the guidelines that's recommended is that. And you sort of think that there's got to be something to that having the RT has got something to do with, how the virus is inhibited. That's what is needed to form a suppressive regimen.
Yeah, I think that's a great point. I mean, we certainly know that when boosted PIs and the non-nukes were put together, they didn't do so well. There were several studies along those lines, and the use of integrase inhibitors with boosted atazanavir didn't do so well either because of some drug interactions and effects on bilirubin. Since you've had so much experience with the injectables, Chloe, what kind of changes would you implement in your clinic before setting up patients for use of these long-acting drug combinations?
I mean, firstly, to say I'm so incredibly excited about this. I think it's going to be so absolutely amazing. I mean, I think the key thing is about maintaining the patients, not losing them. Having systems of contacting people, watertight ways of contacting them, making sure that we know how to diary when the person is meant to be coming, have a system for what happens if they don't come, another person you can phone, like really being careful about what you're doing, and then, just maybe, the good thing about us is we give injections. We give syphilis injections, our specialty. We can give injections into the buttock. It's not a problem to us. So that's not a difficult thing. It's just managing a different way of administering care. And I think that is really the key thing. It doesn't take long to give the injection. It's more about, the how and making it easy for the patient.
Yeah, I agree. I think that managing the patient flow becomes the key issue, as well as tracking, as you mentioned. And to me, the most important thing is for people to present this as an option to their patients. As you point out with your audience reaction, I think there are many treaters who may have a negative view of injections. And it's important that we not make the decision for our patients, but let them decide what's best for them.
Absolutely. Make sure you are equitable in your offer. You make sure that you offer it to everybody and don't pick and choose who you think will be the easiest person to manage. Be equitable.
Absolutely.
Great. Thank you very much, Dr. Kuritzkes and Dr. Orkin. And thanks to our listeners for joining in. As a reminder, to view the full educational program, Key Decisions in HIV Care, on the CCO website, click on the link in the show notes. Please be sure to check back regularly for more episodes on important infectious disease topics. Thanks.